Okay, finally in the last video in this series, and this is not going to be a long video. And with calcium channel blockers and vasodilators, focusing on the big picture stuff, and there's usually not a lot of questions on board exams, but clinically we do use them every once in a while. So, movement of calcium, extracellular calcium ions across the membranes pretty much governs the function of smooth muscle everywhere. Calcium is involved in the genesis of cardiac action potential. Without calcium, there is no cardiac action potential. Remember when we talked about in earlier lectures that what it is that makes calcium the ideal signaling molecule? These drugs, the calcium channel blockers, produce vasodilation, depress cardiac conduction velocity or dromotropism, depress cardiac contractility inotropism, and decreased heart rate, the chronotropism. When we overdose patients with these calcium channel blockers, you can see hypotension, bradycardia, even tachycardia sometimes, conduction abnormalities, altered mental status, seizures, respiratory depression, hyperglycemia, and metabolic acidosis. So moving on to vasodilators, the ACE inhibitors, angiotensin converting enzyme inhibitors. The cardiovascular effects of ACE inhibitors normally involve decreased peripheral vascular resistance, and there's usually no increase in the sympathetic nervous system tone in response to dropping the blood pressure, so no reflex tachycardia associated with it. ACE inhibitors generally result in a reduction in the angiotensin, aldosterone axis, norepinephrine, and plasma ADH level. This decrease in the aldosterone level results in an improved in cumulative plasma potassium levels, so makes them pretty good drug in treatment of CHF and hypertension. And also they affect the cardiac muscle architecture, not architecture, I can't remember the term, and prevent worsening of the cardiac dysfunction essentially. I will look this up for the lecture because I can't remember it. Hydralazine is still one of the most commonly used vasodilators, even though you probably haven't used it very much. It relaxes smooth muscle tone directly without interacting with any adrenergic or cholinergic system, and in fact the mechanism of action is unknown. We don't know how it works. It's most potent in coronary, splanchnic, renal, and cerebral vessel, and it causes an increase in blood flow in each of these organs because of the vasodilation, so direct vasodilation. The decrease in the cardiac afterload that you get from the arterial dilation is beneficial. Sure, it's beneficial in many situations, but there's almost always a reflex tachycardia associated with it. The effective half-life is about 100 hours, and the side effect includes a lupus-like syndrome, this is commonly tested, drug fever, skin rash, pancytopenia, and peripheral neuropathy, this is also commonly tested. And when you give hydralazine to patients, the important thing is not to give a big dose. It's not a fast onset. It takes about 15 minutes for you to start seeing the effect. So, if you give 6 milligram and then 5 minutes later give another 12, then 20 minutes later the patient is going to be super hypotensive. Nipride. We used to use it a lot more often, but I have rarely seen it used nowadays. It's a very potent vasodilator, and it acts directly on the vascular smooth muscle, causes both arterial and venous dilation, causes a decrease in cardiac preload and afterload, so it decreases cardiac work, but it can shunt blood away from the ischemic zone because of the changes in the vascular resistance. Commonly tested side effects are pulmonary vasodilation, that increase in VQ mismatch, and this results in hypoxia, of course, and also a temporary decrease in platelet function, but this is very temporary and it's reversible. It lowers blood pressure within about 1 to 2 minutes, with the effect dissipating about 2 minutes after you stop an infusion. So don't give a bolus. Sometimes you do in a severely hypertensive patient with ST changes, but nowadays we rarely need to use it. We have better agents. High doses can result in cyanide toxicity. This was a high yield test, I think, for USMLE step 1. Nitroglycerin has the same exact mechanism of action as nitrite or nitroprusside, but it's primarily a venodilator, not arterial dilator. Remember, nitrite or nitroprusside dilates both veins and arteries. Nitroglycerin, primary venous. When you give nitro, you increase venous capacitance, so more volume in the veins, and decrease cardiac preload, so you get a decrease in cardiac work. This is one of the major reasons it's part of the MONA for MI patient, at least classically part of MONA. Effects on the arterial side are usually very minimal, except at very high doses. So, does nitroglycerin increase or decrease your afterload? And this may be a trick question. Effects can be seen within about 2 minutes, and they usually resolve within 5 minutes of discontinuing the drugs. So, ideal for infusion. Neceritide is a recombinant form of a human B-type natriuretic peptide. I've never used it. It acts on guanylate cyclase the same way as nitric oxide does, and it primarily results in venous and arterial vasodilation, and this includes the coronary vasodilation. It's more effective than nitro in decreasing the right atrial pressure, pulmonary capillary wedge pressure, systemic vascular resistance, and ultimately improving the cardiac output. The possible side effects include hypotension, headache, and renal dysfunction. That's it, folks. See you in the class on Tuesday or Thursday.